So welcome everyone to the Society of Thoracic Surgeons General Thoracic Surgery Database monthly webinar. Today is Wednesday, May the 14th of 2025. I can't believe we are halfway through the month of May already. On the call today, let's see here, from the STS side, we have myself, Carol Crone, Banuyatsi, Emily Conrad, we have Katie Lothrop from our Data Manager Core Group, Nancy Hennicutt, Paul Meehan, and Ruth Raleigh, our GTSD Clinical Consultant. So thanks everyone for joining the call today. Per usual, nothing too crazy today. We'll kick things off with our STS updates. Then we'll turn things over to Ruth for a little data manager education. And as usual, we'll end things with our Q&A. So if you do have questions, please feel free to put those into the Q&A, not the chat. So again, please put those into the Q&A. It's just easier for me to tackle the questions in one location. We also have the raised hand function enabled, so feel free to raise your hand if you'd rather just ask your question. We'd love to talk to you. Just ensure that your microphone is enabled on your end. All right, so let's go ahead with our brief STS updates. Just a reminder of our 2025 harvest schedule. Those spring 25 analysis reports were released on Monday, April the 28th. So hopefully you all have your reports or in process of looking at those. If you have questions about those reports, please email the help desk for any report related questions. Our fall 25 harvest is currently underway, so we are accepting harvest data for the fall 25, and then just a reminder that reporting period for fall 25 will include OR dates of July 1, 2022 up through June 30th of 2025, and our fall 25 harvest is scheduled to close on September the 5th. The May training manual has been posted, and check out that FAQ summary for a quick summary of the updates. The summary updates include those for March, April, and May. And then also, along with the spring 25 harvest reports that were released, we also released the GTSD executive dashboard on Monday, April the 28th as well. And Carol did give a great overview. Kind of an impromptu webinar where she walked through the GTSD executive dashboard. I believe that a webinar has been posted out on the STS website. So if you'd like more information on the dashboard, please go back and review that webinar. And again, just report related questions, just a reminder, send those to the help desk directly to stsdb_helpdesk@sts.org. Before reaching out to the help desk, please refer to the analysis overview, because many of your questions likely can be answered via the analysis overview. If you're still unsure after reviewing the overview documentation, please, when you do contact the help desk, always, please include your participant ID number. Also, if you can indicate the reporting time period in which you were questioning, and then also screenshots. If you can provide screenshots for a specific table, graph, or anything that you're questioning, screenshots are super helpful to Paul and Banu as they triage those help desk questions. AQO update. I've covered this on previous webinars, but again, just a reminder, we do have new dates for AQO. Unfortunately, the original dates were scheduled during a Jewish holiday, so we sincerely apologize for that oversight. AQO 2025, the date has been moved up a week, so our GTSD and CHSD sessions will be held on Thursday the 25th. Our ACSD session will be held Friday, September the 26th, and then our NMAX and PDMAX session will be virtual on Tuesday the 23rd. No change in our hotel or location. We'll still be at the Grand Hyatt San Antonio Riverwalk in San Antonio, Texas. And again, the dates are September 25th through the 26th. And we are currently accepting abstracts. The submission deadline is Monday, June 2nd at 11:59 p.m. Eastern Time. And I've included a link here to the abstraction submission information and guidelines. So You can find all the information out there regarding submitting your abstract. If you still have questions regarding submission or the guidelines, please reach out. I think Emily will be able to assist with any of those questions. Again, this year we'll have both the in-person and virtual option for all the databases. For ACSD, CHSD, and GTSD. And just a reminder for our newer data managers, if you do choose that virtual pass, this is not a live stream. This is all of our live in-person sessions will be recorded and then posted on our AQO platform, and then you'll be able to go back and watch the recordings of our live sessions. But again, we are not offering a live stream of the AQO sessions. We're still working with our team on cost information. So as soon as we have that cost finalized, we'll be sure to share that with you as soon as possible. Apologize for the delay, but we are again working on that cost information, and we'll share with you as soon as possible. Anything else, Emily, I may have missed regarding AQO? Any other information?
No, just that we have been meeting with the planning committees to talk about topics, and so we're working through that, and I hope to have that on our website by the middle of June, beginning of July. And then in regards to the registration, we are just, to be frank, we're waiting for our meetings team member who handles registration. She was on maternity leave. She'll be back next week. So after she is back, we're meeting with her, and it should be posted, I hope, before the end of May.
Awesome. Thanks, Emily. Appreciate it. All right, that's all that I have for STS updates. I'm going to turn things over to Ruth for our GTSD education. Ruth?
Hey everyone, so I'm just going to go through a few highlights from the training manual most recently. Sequence 690, history of preoperative medications. I get many questions, people asking me whether an immunosuppressant or a medication that has an immunosuppressive effect should be captured in 690. The core group recently discussed this at length, and the decision made was that chronic immunosuppressive therapy should only be captured in sequence 690 if the medications are being prescribed with the intended effect of suppressing the patient's immune system. One of the surgeons pointed out that many medications have an immunosuppressive side effect, even things as benign as medications for allergies, so Zyrtec, for example. And so the intent was not to capture these as chronic immunosuppressive therapy. One example that was specifically given to us by data manager was Prolia injections, and those are not prescribed with the intent of suppressing someone's immune system, even though it does have that side effect. So that would not be captured specifically. Go to the next slide. Psychiatric disorders. Someone asked a great question about whether psychiatric disorders could be captured based only on the fact that that a psychiatric disorder is documented in the patient's problem list. Problem lists are not the same as a medical history that's been outlined in an H&P, and therefore you would not capture a psychiatric disorder that only exists in a patient's problem list. Problem lists are, no pun intended, problematic. Any provider that comes in contact with a patient can add a problem to a problem list, and actually problems can be added to problem lists automatically from external systems, interestingly enough. And so a problem list isn't really a clean source of data for abstraction, which is why we're excluding them. And problem lists also have this status issue. Things can be active and inactive, and they just don't get updated. They're always a hot mess. If you ever look at your own problem list, you'll quickly decide that is the truth. If you want to go to the next slide. A couple of updates on our favorite sequence, ECOGScore. So if an ECOGScore is assigned by a clinician using a range, capture the lowest value that they provide in the range. Also, we've indicated in the past that you can use a crosswalk for reporting ECOGScores. Unfortunately, there is no crosswalk that would be valid for sites that only have documented METs for functional capacity in their record. There's just not enough similarity, so you can't crosswalk those two. But as you can see in the example that I've provided on the screen, you can crosswalk between Karnofsky grading and ECOGScore, and I know that some sites do that, and that's specifically addressed in the training manual. Go to the next slide. A lot of questions get sent into the FAQ inbox about sequence 1875 of an invasion of adjacent structures. Data managers often want to know what qualifies as a great vessel. So we are adopting the IASLC definition of great vessels, which are aorta, superior inferior vena cava, intrapericardial pulmonary arteries and veins. So if any of those have been invaded by the tumor, then you would capture that as an invasion of the great vessels in sequence 1875. Sequence 3670 post-op procedure through new or existing incision. So again, this is something that truly is a very frequently asked question. Instead of reading what's on the slide, it happens quite often, or with some frequency, I guess, that a surgeon will decide to take a patient to the OR in conjunction with another surgeon that is not a cardiothoracic surgeon. Sometimes that's because, like in an esophagectomy, a general surgeon will do some portion of the case and the thoracic surgeon will do another piece of the case. Or sometimes I think the surgeons are just trying to save a patient a trip to the OR. And so they'll do two completely sort of unrelated procedures in the same trip for whatever reason. In those instances, regardless of who performed the part of the procedure that is deemed as being responsible for the return to the OR, it would be captured in sequence 3670. In other words, your cardiothoracic surgeon cannot assign the blame for post-op events to the other surgeon in the room at the same time as them, and then not have those post-op events be assigned to the procedure that they performed. Ultimately, the surgeon leadership agrees that it's the cardiothoracic surgeon's decision whether or not to combine procedures in a single trip to the OR or not. And so they therefore are required to capture, or I guess, required to be responsible for all post-op events that occur. There's an example specifically in the subsequent sequence on bleeding that I put in the training manual as well. That's not outlined here, but you can read that for more clarification. Next slide. Sequence 3720, pneumonia, a patient that has 3 of 5 characteristics of pneumonia as outlined in the training manual and physician documentation of likely pneumonia that is not later specifically determined not to be pneumonia should be coded as yes. At 3720, the patient should be captured as having pneumonia. Next slide. Sequence 3800. No, I've lost the ability to read numbers, Leanne. We're in trouble. Pneumothorax requiring chest tube. A pneumothorax requiring chest tube for any pneumothorax not present preoperatively is captured in sequence 3800, regardless of surgical approach. So if your patient has a CT scan 2 days after their, I don't know, after their right lobectomy, and they have a left pneumothorax and a chest tube is required to be placed for that left pneumothorax, that would be captured in sequence 3800, even though the pneumothorax is on the opposite side of the original lung resection. On the next slide, sequence 4180, postoperative POChyLeakGrade. There was not a designated place in the training manual or direction on how to capture bedside talc fluoridesis performed to manage post-op POChyLeak. The training manual now clarifies that that should be captured as a type 3 leak. The subsequent, the child sequences, sequence 4190 and sequence 4091 would be coded as no. I think those are like return to OR and IR intervention, I think off the top of my head, but you would code no to those because obviously neither applies. I think that's the end of my quick clinical updates for this go round.
Yeah, thanks, Ruth. We do have some questions coming in, so we can go ahead and start to tackle some of these questions. Our first one from Linda, and Carol may be able to shed some light on Linda's question. Why was it decided to no longer use star ratings for thoracic, yet continue for adult cardiac? I don't know if Carol's still available.
I'm here. Can you hear me?
Yes, ma'am.
Okay. It was a presidential task force decision at the STS leadership, surgeon leadership level. If you want more information on that, I would just reach out to the help desk. And I think we have language that was developed to further explain the reasons why.
Yeah, thanks, Carol. Let's see, Mindy, is there a way to export the graphs on the community page on IQVIA? That is a great question, Mindy. While I'm
I
looking
think
at
you have
that,
to take.
yeah,
Oh, I think you just have to. I think you have to do screenshots for
let's do
that.
screenshots.
The other question I wanted to ask. This is Carol on the new executive summary is. Have you received feedback, or have you been able to share this with your surgeons and your administration? And have you received any feedback from those people? If you have, just feel free to put it in the Q&A, or I'll open the chat back up. We were just looking to see if you had any feedback for us on that.
And Leanne, for the exporting the data from the community page, I went in just playing with it just to see if you could do right click and export to Excel. Seems to work.
Yeah, so yeah, I was doing the same thing, Paul. So
Yeah,
um,
it's one graph at a time, but you can get it.
Oh, that's good to know.
oh yeah, export visualization to PDF or
No, I did it to Excel. I
Excel.
didn't. Well, I mean, it might work to PDF, but I did it to Excel.
Okay. All right, cool.
Mhm.
Excellent. Thanks, Paul.
Yep.
That was okay. All right, Mindy. Let's see. Ruth from Karen. One of the 5 criteria to capture pneumonia is leukocytosis. Agreed, generally leukocytosis is captured at greater than 11,000. No value included in manual for inclusion criteria.
That is a great call out, and we should include a value. I know what value I personally have used, but I would refrain from giving that value. We should just make an official one and put it in the training manual. So I'll make sure that gets in there, Karen. And Linda, who I think also asked a very similar question.
Okay, yeah, she was asking the lower limit. Yeah, those are great questions. All right, Mary. So was it Enbrel? I don't know if I'm pronouncing that right. Or other like meds considered immunosuppressants, steroids, prednisone.
Yeah, there's information in this. There's like a list in the training manual. I am pulling it up right now.
Yeah. Okay, I've got the manual open. If you know the page, I can just.
Well, it is page 1. No. Sorry. It's sequence 690, which is page 39.
Okay, it was close. Oh, sequence. What is it?
It's page 39 in the May training manual, sequence 690.
39, sorry. Now I'm slow. Yeah. All right, sorry. Sorry.
So you can see under number 2A, it says indicate if the patient has required the regular administration of corticosteroids or other immunosuppressant or chemotherapeutic medications. And there's a list which includes Enbrel. And it's within the 30 days prior to the principal operative procedure, or, and this is always a good catch by Katie, at the time the patient is being considered as a candidate for surgery.
All right. Dion, can you tell me what lymph node station to code for intrapulmonary and peribronchial lymph node? Can't find it on the illustration on page 120. Great question. No worries, Mary. She said as soon as I said that, I should have checked the training manual. No worries, Mary.
That's all right. Sorry, why am I?
I can answer this.
Oh, you got it, Katie?
I just wanted to display
Yeah.
the diagram, Katie.
It's
Sorry,
not,
I'm
yeah,
looking.
it's not part of the on the AJCC or the IASLC one. I'm not sure which one we have in there. It's not there, but I know you can find it if you look on, there's other lymph node diagrams or information out there. I know the National Cancer Institute, their SEER training module has a link to it. And so normally your peribronchial lymph nodes are going to be level 12. And then the intrapulmonary, or also called interlobar, those are typically your 11. I think I have the link saved. I can pop it in the chat so people can
Oh, thanks, Katie.
refer to it. Yeah.
Oh, I think Brooke put one in. That might be the same one into the Q&A. Thank you. Stephanie, patient had neoadjuvant therapy with complete response, no residual tumor seen. Path shows no tumor staging. Do I include this in the registry?
Assuming that they had a therapeutic resection, yes.
Yeah.
And there's directions on how to do that in the training manual, Stephanie. Like what you need to do for histology grade, etc.
Okay. Sorry, I didn't mean to interrupt.
No, it's okay. Sorry. I
No.
paused.
Let's see. For gene mutation in neoadjuvant red cap manual, should we code other if there is more than one mutation found?
Great question.
I'm trying to see if let's see, 5055. Let's see.
While you're looking at that, Brooke, I'll add that link, the SEER link to the training manual, and I guess it'll be June. So that link is there. And then when we do the next version of the training manual, we'll see if we can't come up with a little bit better of a picture.
Yeah. I'm just looking at the neoadjuvant training manual. We don't have direction on if there's more than one, which one you should choose. That's a great question. We need to address that for. Molecular testing performed. Yeah, that's a great question. We can ask Dr. Broderick on how he would like to answer that. So Laura, if you want to submit that via the FAQ, and then we can send that over to Dr. Broderick to see how he wants us to answer that. But and we'll, I think that's being updated to make it a select all that apply. So just FYI. Thank you.
There's a question that got put into the chat instead of the Q&A. It says, I love the new executive dashboard. Can you tell me with the last harvest spring 2025, did STS not notify sites if they were at risk of not receiving an analyzed report based on greater than 2% missingness?
Yeah, hi Beth. Yeah, I did not send out emails since we honestly, sites have the information within the missing variable report and the data quality report to check your missingness, and also on the participant dashboard. So we encourage sites to use the tools available to them. Now that we also have the executive dashboard with the missingness widget, sites can use that tool as well to help look at your missingness, but we did not send emails out prior to the harvest. Honestly, sending those individual emails is a lot of work. So we just encourage sites to use the tools that you have available to check your percent missingness. It's the MT30 status and the mortality discharge status. So those are the two variables that you need to review to ensure that you have no missing data or MT30 status coded as unknown. While we're waiting for additional questions come in, our upcoming webinars, our monthly webinars, our next 2 monthly webinars are June 11 and July 9th at 2:30 Eastern, 1:30 Central for our monthlies. And then our next quality improvement webinar is going to be held on May 29th, so just in a week and a half, I think. And that's going to be at 3 p.m. Eastern, and we encourage everyone to attend. We will have one of your colleagues, Kelly Rubino from Hackensack Meridian Health. We'll be presenting on our next webinar she'll be presenting on how she's using her STS data to help drive quality improvement within her facility, within her health system. So we do encourage everyone to attend. And then we are still looking for a presenter for our June quality improvement series. So please reach out if you would like to present. But we are really looking forward to having Kelly join us on the 29th and presenting what she's doing at her institution. Let's see. On REDCap, if PDL1 is negative, do we enter 0? Let me go back here. Sorry. The lowest value you can enter is 0. So yes, I would enter 0. Ruth, did you want to answer Dion's question?
I'd be curious if any of the other core group members on the call have coded sick sinus syndrome to AFib post-op. I personally have not and would have to look into this a bit more. The question is, if a patient has a history of sick sinus syndrome then develops AFib post-op, would you code yes to the AFib post-op or not? I don't know, Katie, if you have experience with that.
I have not, I don't think I have, but they're different. So I would still capture the AFib personally. I mean, yeah, they're both obviously rhythm disorders, but they affect different parts. The mechanism is different. So I don't know if there's anybody from cardiac on who wants to comment on that, but I would still code AFib.
Kelly has her hand raised, and I'm assuming it's related to this question. Kelly?
Hi, yes, I agree. Sick sinus syndrome does not necessarily mean they have a history of AFib. I would code AFib if the patient has AFib post-op.
Awesome, thank you. Dion says thank you. And yeah, Catherine says she would also code separately, so 2 different issues. So it seems like we have everyone's doing the same thing, and we have consensus. So and agreeing 2 different issues. And the May FAQ has information on the time frame for 1-year follow-ups been added. I thought we were only doing 30-day follow-up for general thoracic.
It's for one of the optional modules.
Right.
It's hiatal hernia, I think.
Yeah. And I think you did add a FAQ, if I remember.
I did add an FAQ. I think like when you look at the FAQ summary, sometimes it's not entirely clear like what subheading things are under. I think the short name for that one is like, I don't remember what it is, but it's not clear from just the summary what it is. But if you look at it in the training manual, like the section that it's under is not lung or esophagus.
Right. The hiatal hernia 1-year follow-up, I think that's the one.
Yeah.
Yeah. And that's under there you go. It's under the May summary right here.
Yep. Thank you.
Okay. Oh, Kelly, did you still have a question? Okay, no. All right, excellent. Oh, no worries. All right. Any additional questions from anyone? Everyone's super quiet. Just really quickly, while we're waiting for, to see if any additional questions come in. Oh, here's one from Catherine. SSS conduction issue related to electrical issue with SA node. Ruth.
I think she's just commenting on the
Okay.
sick sinus syndrome. I think it's just a statement, not a question.
Okay, thank you. Sorry, my non-clinical self. Thank you. I appreciate you guys.
Oh, sorry. I think I was on mute. Sorry.
Good. Emily, when will the audit list be sent out this year?
I'm going to, my best guess is late May, early June,
We're in the process of getting things kicked off.
Yes.
All right. Natalie, did you have a question? Let's see here. You should be able to unmute. Yeah, then go ahead, Natalie.
Hi, can you hear me?
Yes, ma'am.
Awesome. Okay, so today I was actually abstracting a case that the patient was a primary lung cancer patient, had received targeted therapy prior to their lobectomy. The pathology from the lobectomy was all negative. I guess the targeted therapy did its job. And so I was kind of struggling to code it fairly in terms of they did go in assuming to remove cancer, but the pathology was all negative. And so when it came to like the histology grade, there was none. There was no cancer. So I just left it blank. Anybody else experience this or have a better way to code it?
Hey, Leanne, do you want to pull up the training manual? I think page 134.
Yep. Oops. Let me see. I think I posted it. Hold on. Oh, no, I've got it.
130. Actually, start on page 132.
So, and it tells you to use the the biopsy related histology, but I didn't have anything in my biopsy histology either. Very strange.
I guess my question is if you don't know what type of cancer that you had to start with, like in your initial pathology report, then you wouldn't include the case because you don't know that you have lung cancer, I guess. That's very confusing to me.
Very. Well, I mean, there was some adenocarcinoma, but they just didn't have the histology grade itself.
Oh, so they said it was adenocarcinoma of the lung in your pathology report?
Yeah, but that was like the pre-op, the staging, if you will.
Sure. So I think the
Clinical staging.
direction on page 133, that first FAQ. So if the patient has induction therapy with a complete response, code the histology from the so you're going to code that as adenocarcinoma.
Okay.
And then for 2080, if you scroll down, Leanne.
Yep.
Yeah, this is the one I didn't have anything for.
Yeah, if you don't have a grade, then you're going to capture number 4, unknown, not reported.
Okay. Got it. Thank you.
Yeah.
Somebody said they asked the pathologist to go back and add the grading to the BX specimen.
Oh, I didn't even think of that.
You can do that. They might not have graded it though, because they didn't have enough tissue, but you can always, plead your case.
Thank you.
Sometimes they run out of tissue with those, like the initial biopsies. They're trying to do all kinds of things now, molecular testing, blah, 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 blah. So who knows what happened, but yeah, worth a shot.
Thank you.
Yeah, thank you. Here's another question. If a patient does not qualify for home oxygen but wants it anyway, does that count as discharge with home oxygen? They would pay for it on their own, they stated. Did we talk about this? Or is it something similar?
This is in the training manual, but maybe not. Home oxygen is like a hot topic.
Yeah.
It's very confusing. Sorry, I'm just looking for the
No, you're good.
sequence. I guess it's not in there. Oh wait, no, that's 30 days.
sorry. That's just the new.
Let me look at my notes and get back to you on that one. I know we've talked about this before, so I can update the training manual so that it's more clear. I just don't want to contradict prior direction.
Yeah. Thank you. No problem. Also just a reminder, I know we have a lot of, we have several new data managers. Just a reminder that the GTSD analysis overview can be found out in the IQVIA platform within the library. So let me, for those of you that are not familiar, just really quickly, the library here does have the analysis overview. Also, our quality rating summary is located here, so you can find the Spring 25 Harvest Composite Quality Rating Summary posted as well. So those documents are out and available for you within the library. All right. And I'm not seeing any additional questions from anyone. So anyone have anything they wanted to add? Oh, here's one more question. If in pathology report lung cancer versus metastasis from another primary cancer is pending, usually the case will be presented to the tumor board. If it still can't be decided what cancer it is, do I need to enter this case?
No, if you don't know if you have lung or esophageal cancer, then you would not be required to enter the case. And you should not enter the case and call it lung cancer.
Perfect. All right. Anyone have anything to add from the STS side? May have missed anything. All right. So again, just a reminder, we have our quality improvement webinar coming up on the 29th at 3 p.m. Eastern, 2 p.m. Central. And again, Kelly Rubino will be presenting. So again, we encourage you all to join. Can't wait to have her presentation. And so we're looking forward to it. So we would love to have as many of you join as possible. So with that, I just wanted to thank everyone for attending today. And if you have any questions, again, please feel free to reach out to myself. Or again, all report related questions should go to the help desk. Please send those to the help desk. There were many of you who reached out for your code for the quality improvement webinar. I think I got everyone. If I have not responded to you yet, please resend your email to me so it's at the top of my inbox. So I think I responded to everyone. But if not, please let me know. Please resend. So I can get you your code. With that, thanks everybody for joining, and we'll see you on our quality improvement webinar. Thanks so much. Thanks, Ruth. Thanks, everyone.
Thank you, Leanne.
Thank you.
Thanks, everyone.